dear juniors. So I'll be discussing what an oncologist needs to know about the pathology and biology of urothelial carcinoma. So it is very well the urothelial carcinoma or urothelial tumors have been very well introduced by our predecessors, and also the etiology has also been very well discussed. So I'll start with clinical features. So most of the urothelial tumor present with hematuria. So mostly the low-grade tumors present with painless hematuria, and urothelial carcinomas present with hematuria with irritation or pain during maturation or increased frequency or urgency. Now coming to diagnosis. So the urothelial carcinomas are basically diagnosed either by urine cytology on voided samples, cystoscopy with biopsy or transurethral resection, and imaging. Now imaging has come to play with the special emphasis on VIRAD scoring, in which these multi-parametric MRI and T2 weighted imaging differentiates submucosal tissue from muscularis propria. Thus, they also tell about muscularis propria invasion on imaging studies also. Now, a little bit about the Paris system of reporting urine cytopathology. So, this Paris system was basically introduced to diagnose high-grade urothelial carcinomas. So, if the urine samples which have urothelial cells with high-grade morphology such as increased nuclear pleomorphism, NC ratio, or hypochromasia, we diagnose it as high-grade urothelial carcinomas. What is the significance is that these have a special risk of malignancy. So if we diagnose high-grade urothelial carcinoma or even cells suspicious of high-grade urothelial carcinomas, the possibility of having a malignancy is around 90%. And they have more aggressive follow-up, and it can be followed by cystoscopy, biopsy, and staging. Now coming to pathogenesis. So the molecular biomarkers and pathways involved in bladder cancer are key to understanding its biological heterogeneity and identifying specific subtypes that can be used to predict clinical outcomes and treatment responsiveness to personalized therapies. So bladder cancer commonly harbor chromosomal aberrations which are characterized by either aneuploidies, deletion, amplification that can affect almost all chromosomes. But the deletion of chromosome 9 is prevalent in all either low-grade or high-grade urothelial carcinomas. Now, bladder cancer is believed to develop via a field effect that involves multiple sites in the bladder mucosa, leading to multiple and metachronous tumorigenesis. So, potential pathways of tumorigenesis and tumor progression of bladder cancer have been identified. One is the divergent pathway, which after there is chromosome 9 mutation in the normal urothelium, it can acquire FGFR3 or TERT mutation and can become hyperplastic. With subsequent mutation, it can become either a low-grade urothelial malignancy or high-grade malignancy. So, low-grade urothelial malignancy can subsequently progress to high-grade urothelial malignancy if there is FGFR3 or TERT mutation or MAPK pathway mutation. Now there is a TP53RB1 loss pathway as well, which is directly associated with muscle invasive bladder carcinomas. Now it is true in WHO 5th edition. So we have non-invasive urothelial neoplasms and invasive urothelial neoplasms. So in non-invasive urothelial neoplasm encompasses urothelial papillomas, inverted urothelial papillomas, the incidence of which is very rare, and papillary urothelial neoplasm of low malignant potential, non-invasive papillary urothelial carcinoma low grade, non-invasive papillary urothelial carcinoma high grade, and urothelial carcinoma NC. Now, when we call invasive urothelial neoplasm, it suggests that the malignancy is spreading beyond the basement membrane into the submucosa and subsequently to muscularis propria or adjacent structures. So, invasive urothelial carcinomas can have divergent differentiation with squamous differentiation and glandular differentiation. So, these are locally advanced disease when diagnosed. It can have trophoblastic differentiation. The importance of it lies in its differential from choriocarcinoma, and it can also have elevated levels of beta HCG. Now, there are various histological subtypes as well of invasive urothelial carcinoma. The importance lies in understanding which are of aggressive subtypes. So, micropapillary urothelial carcinoma, nested variant, plasmacytoid urothelial carcinoma, and sarcomatoid carcinomas have very aggressive morphology and they have very poor 5-year survival. Now, let us brief about non-invasive urothelial neoplasms. So, the neoplasms with no malignant potential have very low risk, are very low risk tumor. And this mutation has already been discussed and they are classified as PTA. Non-invasive papillary urothelial carcinoma, low grade, have 50% recurrence rate and 10 to 20% grade or stage progression rate. Now, high-grade malignancies are classified when we find more than 5% of tumor area having high-grade morphology. If it has high-grade morphology in only less than 5% of tumor area, we classify it as low-grade only because it has the prognostic implication is similar to the low-grade malignant tumors. But we give the description that it is a low-grade non-invasive papillary urothelial carcinoma with less than 5% tumor area. So these high-grade carcinomas have recurrence and progression of to invasion is about 60%. Now urothelial carcinoma in situ are very high risk and they usually progress to muscle-invasive bladder carcinomas. They have tendency of BCG therapy refractoriness, but the pembrolizumab can be given to counter this. Now these are usually multifocal and the disease is usually treated with radical cystectomy. Now these days muscle invasive bladder carcinomas are now classified using the molecular subtypes. So there are 6 molecular clusters with different prognostic outcomes. They enriched with certain histological features, immune microenvironments and gene signatures. So these are luminal type with luminal papillary, luminal specified and luminal unstable, stroma rich, basal squamous and neuroendocrine-like. Now neuroendocrine-like, basal squamous and unstable one which have TP53 mutation have worse median overall survival. Now, what are the significance of classifying, having a molecular classification is that we can give targeted therapies to these tumors if we identify the molecular changes. So, the luminal subtype FGFR3 inhibitors, early cystectomy without neoadjuvant chemotherapy can be given. And in luminal infiltrated immune checkpoint inhibitors can be given. In basal squamous, neoadjuvant chemotherapy and immune checkpoint inhibitors are suggested, and in neuronal type, etoposide plus cisplatin-based therapy is given. Now coming to staging, everybody, I'll just briefly describe it for the juniors at the back. So PT stage, PTED is given when there is non-invasive papillary carcinoma. The now recommended. So what is this 2-tier subcategorization? That on microscopy we have to give whether the tumor is microscopic or extensive or whether they are involving any histoanatomical landmark such as muscularis mucosa or vascular plexus. Higher subcategory correlates with recurrence and stage progression. Now PT2 is called when tumor invades muscularis propria. So outer muscularis propria and perivascular soft tissue boundary is irregular, and awareness of such irregularity in cystoscopy specimen can enhance accuracy of PT2B and 3A tumor staging. PT3 tumor invades perivesical soft tissue. So poorer outcome is observed with PT3B tumor, in which perivesical soft tissue invasion is seen macroscopically. So staging relies substantially on gross assessment of perivesical tissue involvement. PT4 is extravesical tumor directly invades any of the pelvic structures such as prostate, seminal vesicle, uterus, or vagina. So prostatic stromal invasion is considered PT4A only if it is contiguous with bladder transmural invasion. Emphasis should be given on extracapsular extension in the report. Now coming to the prognosis and prediction of urothelial carcinomas. So they can have either clinicopathological features in terms of tumor grade. So there is a two-tiered tumor grade as we discussed, low grade and high grade. Then risk of malignancy of non-muscle invasive urothelial carcinomas depends upon high grade with worse prognosis, PT1 stage, tumor size of more than 30 mm. Multifocality is associated with higher mortality and progression. Association with carcinoma in situ causes high recurrence rate. Additionally, disease recurrence, how many times the disease has recurred, lymphovascular invasion and aggressive histological subtypes also play important role in risk stratification. In non-muscle invasive bladder carcinomas, the presence of apobec related mutational signature was found to be associated with a poor outcome. Now, the prognosis of muscle invasive bladder carcinoma are usually high grade and outcome is associated with pathological stage. Higher stage have worse prognosis. Aggressive subtypes, if we give micropapillary, plasmacytoid or sarcomatoid variant, then they are very aggressive tumors. Lymphovascular invasion is an independent predictor of recurrence and decreased overall survival. Now, LVI in absence of nodal involvement is also known to have a worse outcome. Nodal status we have to mention number, density and extranodal extension. So if they increase in number or density, or if extranodal extension is there, it will obviously have worse prognosis. And response to neoadjuvant chemotherapy and time of surgery. So it also depends on hospital and surgeon volume. Has a better outcome. So presence of increased tumor immune cells in TURBT specimens have been associated with better outcome after intravesical therapy. Benefits of immune checkpoint inhibitors in tumors with high PD-L1 expression can be used as a predictive biomarker as well. Now, what are the molecular prognosis and predictive markers? So, in invasive carcinoma, the molecular classification having neuroendocrine-like basal squamous and luminal unstable subtypes have worse overall outcome, and they all have TP53 mutation. Non-invasive low-grade carcinoma, we usually go for high Ki67, which has poor prognosis. Mutation in FGFR3 and CA has lower recurrence rate, and PTEN deletion has increased recurrence rate. Lastly, novel prognostic and predictive markers such as long nuclear RNA, microRNA, epigenetic changes, proteomic signatures, tumor immune microenvironment markers are being investigated in blood and urine samples assessing proteins, RNA and cell-free DNA, and identification of these mutations may be amenable to targeted therapy. Thank you.